Hi everybody, and welcome to our module on the cerebellum. The cerebellum is sometimes called the little brain because it's a separate structure that sort of looks like a brain that hangs off the back of the brainstem. You can see it in this MRI picture here on the screen. And it's very important for posture and balance and muscle tone, and it's also important for coordinating movements. I think of it in some ways analogous to the basal ganglia. When you have lesions of the basal ganglia, this results in incoordinated movements, and the same thing happens when you have problems related to the cerebellum. There are a number of ways to think about the anatomy of the cerebellum, but the way that's most important clinically is to think about the cerebellum as having a central portion, which is called the vermis, and two outer portions called the hemispheres. As we'll see in a couple of slides, lesions of the vermis are different from lesions of the hemisphere in terms of the clinical symptoms. You can also think about the lobes of the cerebellum. There's an anterior lobe, a posterior lobe, and then a small funny-shaped lobe in the back called the flocculonodular lobe. The bundles of nerve fibers that go in and out of the cerebellum are called peduncles. There is an inferior and a middle cerebellar peduncle, and these both carry information into the cerebellum. And then there is a third peduncle called the superior cerebellar peduncle that carries information out of the cerebellum. So let's talk about those inputs and outputs from the cerebellum one at a time, and we'll begin by discussing the inferior cerebellar peduncle. This is the major pathway into the cerebellum from the spine. It's got numerous inputs, including all of these tracts, which you can read about in your textbooks, but the most important thing to remember about the inferior peduncle is that it carries ipsilateral spinal cord information on proprioception, and as I told you before, the cerebellum is important for coordinating movements, so this proprioceptive information coming from the spinal cord is very important, and it enters the cerebellum via the inferior cerebellar peduncle. The middle cerebellar peduncle is the other pathway into the cerebellum. It carries pontocerebellar tract fibers. These are fibers that are coming from the contralateral side of the pons. A long time ago, when anatomists began studying the fibers that entered the cerebellum, they noticed that many of the fibers branched extensively and therefore looked like moss, and they named these mossy fibers. There were also some fibers that did not look like this, and they named those the climbing fibers. So the climbing and mossy fibers are the two types of axons that enter the cerebellum. The climbing fibers arise from the inferior olivary nucleus, and the mossy fibers arise from all other cerebellar inputs. Both of these axons synapse on cells in the cerebellum called Purkinje cells or deep nuclei, and we're going to talk about both of these cell types in a few slides. The final cerebellar peduncle that we haven't discussed is the superior peduncle. This is the major pathway out of the cerebellum. It carries axons that arise from the deep cerebellar nuclei. All outputs from the cerebellum originate from these deep nuclei, which we'll discuss in a few slides. Fibers from the superior peduncle travel to the red nucleus and the thalamus, and these structures in turn can modify motor activity of the cortex. So now let's talk about the important cell types that are found within the cerebellum. The first cells are the Purkinje cells. These are the cerebellar neurons. They receive numerous inputs and project to the deep nuclei, which are the other important cell type of the cerebellum. The Purkinje cells are inhibitory. They release GABA onto the deep nuclei, and by doing this, they modify movements and help to coordinate movement. And this is a drawing of what Purkinje cells look like. They're famous for being highly branched. The other important cell types found in the cerebellum are called the deep nuclei. These are cells that send projections out of the cerebellum. So when the cerebellum wants to influence motor activity, it does so by initiating signals in the deep nuclei. There are 4 deep nuclei. The most important one is the most laterally located nucleus. That's called the dentate nucleus. It has projections that travel to the contralateral VA and VL nuclei of the thalamus. And this is the same part of the thalamus that the basal ganglia influences. So just like the basal ganglia modifies thalamic inputs to the cortex to modify motor movements, the cerebellum can do the same thing. Using the thalamus, it can modify motor activity so that our actions are coordinated. The other nuclei include the interposed nuclei. There are 2 of these. One's called the globose nucleus. The other is called the emboliform. These project to the contralateral red nucleus. And then finally, there is the fastigial nucleus, which has projections that go to the vestibular nuclei and the reticular formation. And here's a drawing showing you how the 4 nuclei of the cerebellum are laid out in space. The dentate nucleus is the most lateral of the nuclei, and that's going to be important later clinically because lesions of the dentate nucleus behave like lateral lesions of the cerebellum involving the hemispheres. The other nuclei are more medial. Those include the emboliform, the globose, and the fastigial. Lesions involving these nuclei behave more like medial lesions of the cerebellum in terms of clinical symptoms. So here's a summary slide of all the elements of cerebellar circuitry that we've discussed so far in this video. I think of the cerebellum basically as a box with a number of inputs creating outputs that will modify and coordinate movements. The inputs include the middle and inferior peduncle, and remember that the fibers coming into the cerebellum are either climbing fibers or mossy fibers. The important cell types within the cerebellum are the Purkinje cells and the deep nuclei. The Purkinje cells can modify the deep nuclei, and then the deep nuclei are responsible for sending signals out of the cerebellum that coordinate movements. In general, each half of the cerebellum controls the ipsilateral side of the body. Now, there are cerebellar fibers that influence the contralateral cortex. However, the motor fibers of the contralateral cortex cross back to the contralateral arm and leg. In other words, there are two crossings. This means that the left side of the cerebellum influences the left side of the body, and the right side of the cerebellum influences the right side of the body. In addition, in terms of sensation, right-sided proprioceptive fibers from the spinal cord go to the right cerebellum and left to the left. The result is that if you have left cerebellar lesions, that will lead to left-sided symptoms, and if you have right cerebellar lesions, those will lead to right-sided symptoms. In addition to left versus right, the other distinction that is important in terms of clinical cerebellar disease is whether the lesion is lateral or midline. Lateral lesions of the cerebellum involve the lateral portions of the structure, like the hemispheres and the dentate nucleus. Remember that of the four deep nuclei, the dentate is the most laterally located. So if you have a lesion that involves one of the hemispheres or the dentate nucleus, these are lateral lesions of the cerebellum, and they tend to involve the lateral portions of the body, like the extremities. On the other hand, midline lesions of the cerebellum, like those lesions that involve the vermis, or the midline deep nuclei, or the flocculonodular lobe, these lesions tend to affect the midline portion of the body, and that includes the trunk. So lateral lesions affect the extremities of the body. They affect the direction, force, speed, and amplitude of movements. These are the things that the cerebellum modifies. So lesions can present as dysmetria. This is where a patient cannot control precisely a movement. For example, if you ask a patient to touch their nose and then touch your finger over and over again, they will miss your finger. That is evidence of dysmetria, which can be seen in lateral lesions. These patients can also have an intention tremor. When they try to move their finger towards an object, it will begin to shake because they cannot coordinate that movement because of a lateral lesion of the cerebellum. In addition, they can have problems in their legs, and these will present as falling toward the injured side. They will not be able to position their leg to plant it properly, and therefore they will fall towards the side of the lesion. In contrast, central lesions of the cerebellum affect the trunk and midline. So for example, if you have a central vermis lesion, this often leads to what's called truncal ataxia. This is where the patient can't stand independently or falls over when sitting. In other words, they are wobbly because they can't hold their trunk in the midline in one position. Also, if you have lesions that involve the flocculonodular lobe, this connects to the vestibular nuclei, so this can produce lesions like nystagmus of the eyes or vertigo, but you can think of both of these as central or midline lesions, in contrast to those involving the arms and legs we talked about for lateral lesions. One of the classic signs of any cerebellar lesion is loss of balance. This is called cerebellar ataxia. And classically, patients who have cerebellar lesions develop what's known as a wide base gait. Their gait is wide because they have difficulty getting their feet to plant in the right place, and if they stand with the feet narrowly together, they will fall over. So by putting their feet further apart and developing a wide base gait, they have better balance and they avoid falls. The Romberg test is a test that can be performed clinically when a patient has ataxia or loss of balance. It's a test to determine whether the ataxia is sensory. It's not a test for cerebellar ataxia. What happens is when you lose proprioceptive information coming up from the spine, patients often compensate through vision. So in other words, they can't feel where their feet are in space, but they look at their feet and therefore they're able to maintain their balance. To do the Romberg test, you ask patients to put their feet together and close their eyes. If the patient has a positive Romberg test, they will lose their balance or fall because you have taken away the control that is resulting from vision. So if the test is positive, the patient has what's known as a sensory ataxia. It means that they are unable to sense their feet and they are using vision to compensate. Patients who have a cerebellar lesion and have cerebellar ataxia will have ataxia that occurs even when the eyes are open. In other words, adding sensory information from vision is not enough to compensate for the ataxia from a cerebellar lesion. It can only compensate if you have a sensory ataxia due to loss of proprioceptive information in the spinal cord. Let's go through some of the other clinical symptoms you can see in patients who have a cerebellar disorder. Remember, the cerebellum is important for muscle tone as well as coordination of movements. So patients who have cerebellar disease can have hypotonia. They can have loss of muscle resistance to passive manipulation. They often have loose-jointed, floppy joints because the muscle tone is lower than normal. In addition, patients with cerebellar symptoms often develop what's called scanning speech. This is irregular speech. Remember, they cannot coordinate movements, including mouth movements, to speak properly. So something like "how are you doing" might be uttered by a patient with cerebellar disease as "how are you doing," with lots of spaces and irregularity to the speech. And then finally, dyssynergia is a classic symptom of cerebellar disease, so let's talk about that now. Dyssynergia is loss of coordinated activity, and it can manifest in a number of different ways. First of all, you can have dysmetria, which I mentioned before. This is loss of movement coordination where patients under or overshoot the intended position of their hand. This can be tested clinically by asking the patient to touch their nose and then touch your finger repeatedly. Dyssynergia can also manifest as an intention tremor. You can't get your hand to a target. This is in contrast to the resting tremor that can be seen with Parkinson's. And then finally, patients with cerebellar disease who have dyssynergia often manifest what's known as dysdiadochokinesia. This is where they can't make movements exhibiting a rapid change of motion. This is often tested clinically by asking the patient to flip their hand over and over in their palm. They won't be able to do this because this movement has to be coordinated and the cerebellum is necessary for that coordination. And then finally, some other cerebellar symptoms include nystagmus. You can see upbeat or downbeat, so-called vertical nystagmus in cerebellar disease. You can also see gaze-evoked nystagmus, which is movement of the eyes in gazing in one direction or another. And then finally, nausea and vomiting and vertigo are also nonspecific symptoms that can occur in cerebellar disease. I'll finish this module by talking about cerebellar disorders, and I'll start by reviewing cerebellar strokes. I review these in detail in the neurology modules on stroke syndromes, but by way of review, the blood supply to the cerebellum includes the superior cerebellar artery, the anterior inferior artery, and the posterior inferior cerebellar artery. These three vessels deliver blood to the cerebellum, so a stroke involving any of these three blood vessels can lead to any of the cerebellar symptoms we talked about on the last few slides. In addition, these patients often have other brainstem stroke signs and symptoms, and I talk about all this in other videos. Now let's talk about the hereditary ataxias. There are a number of rare disorders called hereditary ataxias. They all lead to motor incoordination related to disease of the cerebellum. The two that you need to know as a medical student for step 1 are ataxia telangiectasia and Friedreich's ataxia, so we'll talk about these now. Both of these are examples of autosomal recessive hereditary ataxias. There are other hereditary ataxias that are autosomal dominant and X-linked. So ataxia telangiectasia is autosomal recessive, and children born with this condition have cerebellar atrophy beginning in the first year of life that is progressive. In addition, they often have telangiectasias, which are skin lesions that result from dilation of capillary vessels on the skin. They're typically found on the ear, nose, face, and neck. That's why the disorder is called ataxia telangiectasia. In addition, these children are immunodeficient, and for that reason they have repeated sinus and respiratory infections. And then finally, as we'll discuss in a minute, these children have DNA damage, and as a result there's a high risk of cancer over their lifetimes. Most children born with this condition are healthy for the first year of life, and they may even begin walking at a normal age, but thereafter their development becomes slow. Over each successive year they have progressive motor coordination problems, and by 10 years old most children with ataxia telangiectasia are in wheelchairs because of loss of balance. In addition, they have the other symptoms I mentioned on the last slide: recurrent sinus and respiratory tract infections, and telangiectasias may be present on the skin. And then finally, these children have a high risk of cancer, and this is the thing you want to remember for your boards. It's likely that they will ask you what may happen to these children over time, and they want you to be aware that the risk of malignancy is what may ultimately take their life. The cause of ataxia telangiectasia is DNA that is hypersensitive to ionizing radiation. We are all exposed to ionizing radiation at a low level constantly, and our DNA needs to be able to repair itself. Children who have ataxia telangiectasia are unable to do this. The reason is that they have a defective ATM gene, which is found in chromosome 11. ATM stands for the ataxia telangiectasia mutated gene, and this gene creates a gene product that repairs double-stranded DNA breaks. It carries out a process known as non-homologous end joining, which I'll describe on the next slide. But the result of a mutation in this gene is that these children have a failure to repair DNA mutations which occur in response to ionizing radiation. One of the reasons they like to ask you about this rare disorder on your boards is because there's a tie-in with molecular biology. When we're exposed to ionizing radiation, we can develop double-strand breaks in DNA. Non-homologous end joining is the process of repairing those two ends and bringing them back together. This is in contrast to homologous end joining, which is another repair process, but it requires a template strand. Non-homologous end joining does not require a template strand, and it repairs DNA breaks and brings the DNA back together. In addition to the clinical features I've already described, there are two peculiar lab abnormalities that are often present in ataxia-telangiectasia that you should know about. The first is an increased level of alpha-fetoprotein. You may know that the plasma level of AFP is often elevated in pregnant women, but it's also elevated in children with ataxia-telangiectasia. This is the most consistent laboratory finding. And then second, there is often a dysgammaglobulinemia present. This means that these children have abnormal levels of immunoglobulin. In particular, they usually have very low or absent levels of IgA in the serum. The second hereditary ataxia we'll discuss is called Friedreich's ataxia. It is also autosomal recessive, just like ataxia-telangiectasia. This disorder is caused by mutations of the frataxin gene on chromosome 9. This gene is important for normal mitochondrial function. Children born with this condition have an increased number of trinucleotide repeats. Specifically, they have an increased number of GAA sequences present in their frataxin gene. The more repeats that the child has in the frataxin gene, the worse the prognosis. When you have trinucleotide repeats like this in Friedreich's ataxia, it leads to decreased frataxin levels, and that's what leads to the clinical symptoms of Friedreich's ataxia. Frataxin is a mitochondrial protein, and there are high levels found in the cells in the brain, heart, and pancreas. And if you can remember these three organs, it can help you remember the strange clinical syndrome that develops in children who have Friedreich's ataxia. Abnormal frataxin leads to mitochondrial dysfunction, and that leads to symptoms in all of these organ systems. Children with this disorder develop normally until they reach adolescence or sometimes young adulthood. At that point, they develop progressive neurologic symptoms. That's usually what brings them to medical attention. There is degeneration of the cerebellum and the spinal cord. In particular, there is degeneration of the spinocerebellar tract. This leads to ataxia and dysarthria. There's also loss of the dorsal columns of the spinal cord. This leads to problems with position and vibration sensation. In addition, there's loss of the corticospinal tract, so you can see upper motor neuron weakness in the lower extremity in patients with Friedreich's ataxia. The neurologic symptoms are usually the dominant clinical features. However, there are other features related to the other organ systems where the frataxin gene is important. One of these is the heart. People with Friedreich's ataxia can develop hypertrophic cardiomyopathy, and this is how I've taken care of a couple of these people in my career. In addition, they often develop diabetes. They can develop insulin resistance and impaired insulin release. This is all due to beta cell dysfunction. And then finally, what's often most readily apparent when you meet people with Friedreich's ataxia are the spine and foot abnormalities. So people with this condition often develop kyphoscoliosis, which is an abnormal curvature of the spine. This is a picture of a child with kyphoscoliosis. The spine is curved both in the lateral direction and in the anterior-posterior direction. And then secondly, patients with this disorder often develop foot abnormalities known as pes cavus. This is a very high arch of the foot. The foot does not flatten with weight bearing. This is a picture of what that looks like. And this is seen in other neuromuscular diseases as well. In particular, it's a typical feature of Charcot-Marie tooth disorder. So now we've talked about cerebellar strokes and hereditary ataxias. I'll finish with this slide on other cerebellar disorders. I talk about all of these in other videos in the neurology section, but I just want to remind you that there are a number of tumors that can involve the cerebellum. There are also a number of congenital disorders, including Dandy-Walker malformations and Chiari malformations, that can affect the cerebellum. And that concludes our module on the cerebellum.